Uh, yes, First, I'm not good at speaking English, sorry. Introduction. Paratuberculosis is caused by the infection of Mycobacterium avium subspecies, paratuberculosis. Clinical symptoms of the disease are chronic enteritis, decreased milk production, wasting, and eventual death. There is abundant evidence of fetal infection via intrauterine transmission of MAP. The frequency is high as 37% in cows with clinical signs of PTB, compared with 9% of fetuses in cows without signs of disease. Since cows infected in utero tend to become high shedders with clinical signs, elimination is one of recommended control measures. It is difficult, however, to eliminate all calves born from cows diagnosed with PTB because of the consequent high economic loss. There is no compensation if calves did not shed MAP. The aim of this study was to evaluate fetal MAP infection based on maternal histopathological examination, which could then allow for effective and efficient PTB control. In Japan, cattle diagnosed with PTB by qPCR, the officially recommended diagnostic technique for PTB in Japan, or by isolation of MAP were culled according to the domestic animal infectious disease control guidelines with a low level of compensation. In Tokachi District, Hokkaido, between July 2016 and March 2017, 22 culled pregnant cows were histopathologically examined. The fetal age was 4 to 9 months. The fetal specimens examined included the heart, lung, kidney, liver, spleen, ilia, jejunum, colon, and meconium. The maternal specimens included the umbilical cord, caruncle, umbilical blood, amniotic fluid, ilia, and feces. For histopathological examination, tissues were fixed by 10% neutral buffered formalin and embedded in paraffin, sectioned, stained with hematococylin eosin stain and Thiel-Nielsen stain. Classification of disease regions was undertaken using two indicators: the observation of Langhans multinucleated giant cells and epithelial cell self-infiltration, following classification described in previous studies. N-type showed this type, no specific PTB pathology, while T-type showed tuberculoid lesions such as multinucleated giant cells. TL-type showing both tuberculosis type and lepromatous type, and L-type, lepromatous pathology, consisting of epithelial cell cluster were observed. The severity of lesion is accompanied by a shift from N-type to L-type. And likewise, the amount of MAP DNA is also increased when accompanied by this type shift. For this, from this slide, we show the histopathological figures of the area from mild region to severe region. The top picture are HE staining, the bottom picture are the N staining, the left picture are low power field, the right picture are high power field. This is N-type area. The normal structure of intestinal berries is maintained and shows no specific PTB pathology. This is T-type area. This type shows region resistant to the MAP infection, including macrophage infiltration in the apex of the virus, and the formation of multinucleated germ cells. Acid-fast bacilli in the cytoplasm of the giant cells are visible on DNA staining, difficult to see. This is T-type area. This is showing the combined characteristics of tuberculosis type and lepromatose type. Green circle, this shows multinucleated giant cells as T-type lesions. And red circle, red circle, the accumulation of epithelioid cells as L-type lesions. Many acid-fast bacilli is observed in these cells by the N staining. This is lepromatose type ER. Epithelioid cells are diffusely infiltrating in the mucosal wall of ileum. The cells are shown to accumulate predominantly between the laminopropylia and muscular layer and have caused severe mucosal thickening. Many acid-fast bacilli are observed in the cells. Multinucleated giant cells were not observed. In previous studies, we have shown that a multinomial logit model can predict the histopathological classification type by measuring the amount of MAP DNA. Histopathological classification and amount of MAP DNA are related to each other. This graph shows that as the shedding level gets higher, histopathological type also progresses in the order of N, T, TL, then L types. To evaluate fetal infection, first, histopathological examination was done using the same method as described with the previous slides. In the culture test, we suspended specimens in sterile distilled water, added hexadeciylpyridinium chloride solution, then incubated in hard egg yolk medium, and then incubated the medium for 3 months. For statistical analysis, we used the binomial logit model to evaluate fetal infection based on amount of MAP DNA in feces quantified by real-time PCR. The histopathological type of ileum from the 22 pregnant cows were classified. 7 were N-type, 8 were T-type, 2 were T-type, and 5 were L-type. These results are from the culture test. The number indicates CFU isolated from each specimen. MAP was isolated all L-type carbuncle and almost all umbilical cord. Also, MAP was the most frequently as it was isolated from the liver of 4 individuals. MAP was also isolated from 1 heart, spleen, kidney, and ileum. It was not isolated from lung, jejunum, colon, meconium, umbilical blood, or amniotic fluid. On histopathological examination, fetal specimens showed no region specific for PTB, neither in the maternal umbilical cord nor the carbuncle. This shows isolation rate of MAP from fetal specimens. MAP was not isolated from the fetus in N-type terms, while it found in 25% of T-type, 15% of T-type, 60% of L-type. So isolation rate of MAP from fetuses increased depending on the level of severity of histopathological types. This slide shows the rate of fetal infection based on the amount of MAP DNA in maternal feces. The rate was calculated using the binomial logit model, and it indicates fetal infection rate increase with the amount of MAP DNA detected. In previous studies, we have shown that a multinomial logit model can predict the histopathological classification type by measuring the amount of MAP DNA. It indicates that fetal infection rates increase with high rates of severe lesions. In this study, if maternal ilia was N-type, MAP was not detected in fetal specimens. However, if maternal ilia was T-type, TA-type, or L-type, MAP was detected in fetal specimens. These results suggest that fetal infection rarely occur from dams showing N-type. On the other hand, with severe lesions in maternal ilia, there were higher rates of fetal infections. Likewise, there is also correlation between an increasing amount of MAP DNA in maternal feces with fetal infection rates also increasing. We believed the most frequently MAP isolated fetal organ was the liver. Likewise, MAP was also isolated from the maternal caruncle and umbilical cord. This suggests that fetal infection was caused by umbilical cord blood. However, the mechanism of spread of fetal infection across the strong placental barrier is still unknown and requires further investigation. In conclusion, cows with lesion classified as type L showed high rate of fetal infections. To eliminate or repetitive test the last bone calf from type L dams is strongly recommended for effective control of PTB. Thank you for your attention.